of history. We've been working on this internationally for more than 5 years, which means that there is a lot of knowledge that has been generated. We've had all the international workshops where experts have produced manuals on medical ethics, on physical security of hospitals, on operating ambulance services in risky environments, on the legal frameworks. So there's this entire body of knowledge, and there's all those manuals, literature that you can resort to, and you can adapt it to the local context and the local environment, and make it useful for the people here.
Well, I think it's a brilliant project. It's very close to our heart. We all have faced all sorts of violence in our lives. I've worked here for 25 years, 25 odd years actually, and I have seen a number of cases in which, such violence takes place. Nurses have been assaulted, doctors have been assaulted. We've had a shootout in the emergency. We've had people wearing these suicide jackets and coming into the emergency. We've had people using weapons and other than the law enforcement agencies. I think this is something that needs to be touched long time ago.
Early on in the project, we identified Karachi as the best site to start our healthcare in danger activities. The first and the most obvious reason is that Karachi faces levels of violence against healthcare that are not typical for the rest of the country. Second of all, it's also a place that is readily accessible to the ICRC, but also it's a place where you already have a very vibrant civil society, you have NGOs, you have universities, you have a vibrant intellectual and academic life, you have an organized medical community, and this was very important for us in terms of finding partners and creating a community of concern. It's a metropolis of more than 20 million people, and the scope of this humanitarian problem here means that a direct intervention, ICRC acting solo, wouldn't really be able to bring about any meaningful change. So that's why I think it's really important that we are partnering with local organizations, and that we are trying to address problems at the policy level.
It was a kind of a shock that came from healthcare providers, and of course the community people were as well. They said that we did not know how to deal with violence because it wasn't taught. So if somebody comes up to me and I'm a physician or a staff nurse or a safety guard or somebody who's an allied health person, I did not know that if somebody is attacking me, what do I do?
There are enough laws that, if implemented correctly and if undertaken properly, will bring about positive change nonetheless. So you have the tools, all you have to do is apply them, you see, as opposed to just putting them on the conveyor belt where they go round and round.
Most of the projects that I have worked on in public health were generally about doing research or developing a training program, assessing if there has been a change in the knowledge and attitudes. But in this project, I think it is not just the research component which kind of gives me that high in research. It's about the interventions that we came up with. It's about how and what the stakeholders said that I think it's going to make a difference in the lives of the people, at least in the city, not in 1 year, but of course in due time, because this project is not kind of ending here. This is not like a research project you